Thank you very much to all of our speakers. It's always interesting to see politicians lined up and speaking side by side. Now, of course, it's your opportunity to ask them the questions that you have been dying to ask. So I'm here to facilitate that. I'm also getting old, so I've got to put my specs on. So who would like to ask a question? Right, there's a roving microphone, and if you would, once you get the microphone, if you would like to identify yourself and then ask your question. Thank you.
Felicity Goodyear-Smith. I'm the head of the Department of General Practice at the University of Auckland. And as Tim Malloy said, we want 50% of our GPs, of our medical graduates to become GPs, and it's not happening at the moment. At the moment, it's about 17% of our graduates are choosing general practice. I went to the UK last year and I visited 11 of the 33 medical schools. They also want the same goal. They're getting about 30%. One of our main barriers is that it's my responsibility for half of the medical graduates or half of our medical students in New Zealand to actually be placed into general practice, to have a general practice experience, to be taught general practice. We struggle to get enough practices to put our students into, and to put our students into early. And that's mainly because we can't pay practices sufficiently for them to take our students. Now, it costs GPs to have students sit with them, to have a room, to have a computer, to actually have the time to teach them. In the UK, they've got ring-fenced money. I would like to put a challenge to all four of you as to how do you see that we could move forward actually providing some funding for general practices to take up an apprenticeship model and actually train and enthuse and inspire our medical graduates to choose general practice as a career.
Thanks, Felicity. Who would like to answer first?
All right. I suppose we have got some models that we could look at. The new graduate nurse to practice I talked about. And if that was to work well, you could see nurses going into general practice. I mentioned that. But there's nothing stopping saying let us try new graduates into primary health care as part of the funding that goes with them that makes them attractive to receive a position. I think that Kevin was right in that we're going to have to try some different ways of getting our surplus of doctors into general practice, and also our new graduates who are coming out of our medical schools into general practice. I'd be really interested to know how it's going with the recruitment from rural communities and the idea that they would go back into rural communities. And we must have some of those graduates coming out about now if they're not already out. And we've got a whole lot more going in. So we're looking 6-7 years out in terms of what's going to happen in the future. So those that we've got now, then let us try some of those things to see if that works in terms of them getting experience of general practice, find that actually this is a good option. I don't need to follow down the path of a specialty. I like this. But unless we try it, you're going to continue with the difficulty we've got. So I'm up for us trying different ways to make it work. I think what people are sick of, though, is us trying whole new workforces to do things, or a lot more reports about how we need to do it. I think we've got to the point where if we don't actually undertake some real action and try some real things, we'll just stay where we are.
One of the things that I do agree with what Kevin Haig mentioned was the huge need to integrate secondary and primary care. In fact, the advice to the incoming Minister of Health, dating back from about 1989, is that the greatest gains in health would be from health promotion, disease prevention, and the integration of primary and secondary care. And despite this, as Tim says, from 1991, our general practitioner workforce has diminished over successive governments from 50% down to 40%. So how do we reverse that trend? And is that a trend that has happened around the world. Yes, it is, unfortunately, and perhaps that's to do with the fact that medicine and surgery has become more sophisticated, and there is a place for greater specialisation in a whole variety of areas, so that even within the specialties there are super specialties, as you know. Is the place of a general practitioner as important today as it was in the past? In New Zealand here, we clearly have signalled that integrated family practices throughout the country are one of the ways to ensure that we have that collaborative team. And secondly, the government has signalled the need to try and have locality agreements throughout the country where resources would be put from secondary care into primary care, so that within the community specialists can work with general practitioners. My answer indeed is yes, primary care remains one of the most efficient, effective and profoundly important parts of the healthcare spectrum. My own view is that it shouldn't be a compulsory system, but it can work through incentives. And that is where, by ensuring that there are opportunities like voluntary bonding, like GP scholarships, like, as you say, good support for placements in general practice, both in the urban but particularly in the rural centre, are there. And I note that right now the Royal College of GPs funds 35 GP rural rotations per annum at 30,000 per trainee. Of course, that's the sort of thing, in my view, that has to be expanded. So indeed, I think this is something that any government of the day must be putting incentives into, so that we get that shift back to 50%.
So sorry, just to get a specific answer to the specific question, because we did kind of land on the lily pad, but just at the very end. So Felicity's question was pretty clear to me. What Felicity was asking was this question of ring fencing money, which would be available for GPs to pay apprentices, essentially, so that they weren't out of pocket when they took the time to have a young GP straight out of school training with them. Was that the question? Sure, that's right. But
so when they become graduates, they then choose general
Sure.
practice, but they don't get to get exposed to general practice sufficiently when they're actually medical students.
But you want funding available to do that?
Yes.
Right. So Paul,
Yep.
yes or no? Would you support funding for that?
In essence, yes, we're doing it already, but not enough. I accept that.
All right.
Can I just
Question
make
at the front.
a couple of points? Can I just make a couple of points?
Where are you?
I'm here.
Oh, yes, sorry. I thought it was someone out here. I'm
yeah,
thinking
sort
it's the voice from the void. But no, it's the Green Party. So
So the ghost who walks, yes. I wanted to make a couple of points. I think several people have made comments about this mismatch of graduates coming out of training and finding places in the workforce. And I think that clearly we need to be doing a better job of planning out the entire pipeline. So that starts, in fact, before training even, takes a person through training and into the workforce. And each aspect of that pipeline has got to be properly funded. So, point one. Second point, when we were on the West Coast, we supported the Hawke's Bay incubator program for kids who are in secondary school who were maybe thinking about health training. We had scholarships for those young people as they were leaving school and entering training for health careers. We very active part of the rural immersion scheme. In fact, West Coast it still is. And at every point, what we were trying to do there was actually support whatever was required to enable that pipeline to work. And I think as a whole system, we've got to do that.
Barbara, do you want to say something?
Yes, I will. I'll say absolutely yes. We focused a lot of our policy on ensuring that medical students came out of training with the least possible hassle to reduce their student loans, and this is one way that we believe that it should be done. So our answer is definitely yes, we would support that.
All right, we'll come to your question in 1 second. One little bit of housekeeping I needed to remind you of, because I forgot, is that all of the parties' policies on health are available on the conference app. So if you go onto the app, you'll find all of the policies in more detail, and if you want to have a conversation, hopefully not really while this is happening, but I know that's what people do now, you can do it on Twitter, which is @RuralGPs. See how modern we are? Right. Just flick the, has it got a button? Yep.
Australia has just announced that they'll increase the practice incentive payment for teaching students to $200 per half-day session that you have a student in your GP practice. Can you guys match that? Sorry. Australia has just announced that they will pay $200 per half-day session to support general practitioners having medical students in their practice. This is vital in order that we can socialise our medical students into understanding the joys of general practice. I want to know if you guys can match $200 per half-day session.
Who would like to go first?
Well, I would say that none of us probably will say that, because that would be wouldn't be possible to say, yes, we'll just do that at 200, that'll make you happy. But the principle that you're talking about is one that we need to look at, and whether it's $200 a half day or what the payment is, it is the payment to support the cost of the time that is taken and the inconvenience and the teaching that must take place. So there would be a payment, but I'm not going to say it's going to be $200 Oz. Although we could have parity with their dollar very soon. But obviously there needs to be a payment that relates to a New Zealand situation.
Yeah. The practice should not be out of pocket.
Look, as you can imagine, if I said yes, Tony Rao would hang me.
He's going, don't worry.
But look, I totally agree that it's all about incentives and realistic ones, and I think, as I explained, we need more.
Yeah, there does need to be some incentive, and we'd support any moves along those lines.
All right, now we have got heaps of questions, so can I just ask the politicians from here on in, let's try and keep the answers to the questions as snappy as possible so we can get through as many as possible. Yes?
Oh, hi. I'm Jan Bills, a long-term rural GP, and I just want to raise the issue of keeping it with the universities. I have a personal experience where my daughter did an arts degree, then was highly successful in the workforce, decided to go back into medicine, was a rural student most of her life in a small community, applied to the university for a rural position, and so she could cut a year off her training, got an interview, but 2 days before was said, although she had high grades and everything in her arts degree, she was told that she had not enough biomedical subjects, and therefore she would have to do a 6 years. She was a young mother with 2 children and said, I'm not going to do that, I'm going to apply to Australia, sat the GAMSAT exam, was one of the first 6 students to be chosen for Flinders University, which is one of the highest to get into, hardest to get into, and she is now, she wants a generalist career. It's going to be in community geriatrics with palliative care, something we all need in New Zealand. She will not come back to New Zealand. She's now well entrenched in Adelaide. I was in the university myself. It was always my concern that biomedical science is very important, but we are missing a lot of the humanitarian students that are required for general practice. There is a mixed arts science we need to be pushing, and I wonder what sort of pressure you guys might put on the universities to actually look at the graduate students who might come through with the humanities.
All right, who would like to take that? Paul, perhaps you first?
Look, I agree that there's perhaps too much rigidity, both within the university medical school entry requirements, and I'd even go as far to say within the medical council. And we've seen that with graduates from overseas, where highly competent people don't come in. However, clearly one's got to measure that with merit and competency, but I agree in principle there needs to be greater flexibility.
I think this is an area that's rather hard for politicians in terms of directing universities, because as you know, they are fiercely independent, and I suspect that this is an area where you can have a greater pressure on universities through your colleges and so on than we can in terms of the sort of person and the background they come from. But I do agree with you that the best health professional doesn't have to be the person who was top in maths and science, that they do need to have other characteristics and attributes to make a good health professional. But there is one area that we can deal with, and that is the change that was made to not allowing students to have the student loan after 6 years. And this particularly affects medical students, dental students, and probably clinical psychologists. And we have said that we will remove that. That is ridiculous. Many students, like your daughter, could have done a humanities degree or a BSc or something, and then they go into meds or into dentistry, and their student loan cuts out because it takes longer than the 6 years, having used up some of those years already. That will become a disincentive, particularly for women who might be returning after another career, and certainly for those on low incomes who cannot afford to pay for themselves after their time has run out. And you will start to get an even narrower focus of those that will be going into medical, dental school and so on, unless we change that.
I agree with those comments, and just add the locked room.
Okay, we agree with those comments as well.
All right, this gentleman here.
Campbell Murdoch, is this working?
Yep.
Yeah, I'm one of the old deadbeat GPs, age 72, still having to work. Terrible, isn't it? And I agree with Paul about the integration of secondary and primary care, but first of all, let's awaken primary care. Of the people I see in my practice, all but 4% are handled where I am. 4% are referred to secondary care. 1% have to go that day. So the problem I have is, how do we awaken the sleeping giant of primary care? And there are 3 little letters that I haven't heard from our politicians this morning, and they're called PHO. Isn't it interesting? Nobody mentioned PHO. Are they all going to kind of abandon PHOs in their next iteration of policy? Because I believe, as clinical advisor to the Southern PHO, that this is a great way of awakening the primary sector so that we take our real place. We do 90% of the work in healthcare in this country with 10% of the budget. And I think that's got to change.
All right, your point is made, and the question or the challenge to each of you. Would you like to respond?
Really interesting observation, Campbell. None of us did. In fairness to myself, that when I talked about re-engineering models of care, actually PHOs, I think, are the engine to do that, provided that PHOs actually set out to achieve the goals that were in ANET's primary healthcare strategy, all of them, and are not just IPAs and drag.
I'm sorry we didn't mention PHOs, but I did mention primary health care and what I believe we ought to have in them. I want to start off by saying 72 is not old. The closer Paul and I get to it, the younger we think it is, actually. But I'm not looking for structural change, a change of government. I don't think we need huge structural change. I think that people are tired of that, but I am interested in looking at two main funding streams. The funding stream to primary health care, particularly very low cost access. And when we look at funding for very low cost access, it is woefully inadequate. It came to $5.40 per person per year from your $4 million over 4 years, 16 million. It is not enough to make a difference for those who are in great need. It's also a formula that is very rigid. You're either in or you're out. So I am interested in looking at particularly around that funding formula, but secondly around the population-based funding formula. And we need to look at, and it hasn't been done for a long time, and it's been pointed out that's kind of got bits added to it and some of it doesn't make sense. But it is time to look at what is the weightings in those and whether there should be new weightings, whether the weighting for rurality, for example, is sufficient. And I think that is something that requires urgent attention, but not huge structural change. PHOs was something that I believe in, but I also agree with Kevin that they do need to be driven by a primary health strategy which is around collaboration, including with patients and with the community and with those who provide.
Paul.
I've just got to take exception with the point that certainly when I was talking about rural funding and the change to alliancing, I was trying to emphasise that indeed the negotiations were between your network, the ministry, DHBs and PHOs. I agree with Annette that it only has caused in the past in New Zealand huge distraction when we undergo major infrastructure changes. I think this is one of gradualism, but I go back to what I said earlier, that the shift that Tim Malloy pointed out in terms of 50% to 40% is one I do think that we've got to recorrect. In terms of low access funding, it's actually gone up from 27 million in 2007-8 to 50 million now. It's an area indeed that probably does need adjusting, just like the population-based funding does. We talked to a variety of DHBs on this over the last few months. Some of them said it was great, and others said it did indeed need fine-tuning. So all of those things add up to the fact that primary care funding over time has to be adjusted in that direction.
As far as we're concerned in New Zealand First, PHOs are important. We would not support any more structural change within the system. We believe that people are tired of the changes that have happened in the system.
All right, let's move on. Yeah.
Hi, I'm Rachel Hale. I'm a nurse practitioner, older person in general practice. Now, this has been really nice, and I'm just going to stand up here. Nursing seemed to be forgotten in this discussion. And another little point, sorry, that nurse practitioners don't aspire to become GPs. Now, we're talking about how workforce and health in rural New Zealand. Nursing workforce is about to face a shortage. The Australian nursing workforce in 3 years, they're talking about 47,000 shortage. That's more than in New Zealand's total nursing workforce. So and rural is going to be the first affected as the economy tightens and things like that. Our nurses in rural communities will go where the jobs are. And like Dr. Bills has just said, her daughter's gone to Australia for medical reasons. Our nursing workforce is going to do the same. You add to that, to become a nurse practitioner takes more than 6 years, and you're right. And with the student loan thing cutting out at 6 years, unless they can get health workforce funding, it's you pay for it yourself, and nurses can't afford that. So my challenge to all of you is you need to look to your nursing workforce.
Thank you.
I want to have a first go at that. I certainly haven't forgotten nurses, and when I talk of primary care, I talk of the primary care team, and I hope I made that clear when I spoke at the beginning. And that primary care team is nurse practitioners, but it is other nurses within our community, and it is also allied health workers, of which we have quite a number, and also our unregulated health workforce. And I think that we are not taking enough notice of how we integrate that team together. So primary care to me is made up of that workforce, but of course the questions to date have been around general practice. So I think it would be fair to say that we're not forgetting nurses. In fact, rural practice won't operate without nurses in many parts of New Zealand, and general practice knows that. I don't think there is the old divisions about this is our job and this is your job. I'm pleased to see much of that has broken down, often through necessity, so that the right job's done at the right place at the right time.
Paul?
Yeah, look, the government record is pretty clear. 2,000 extra nurses over the last 5 years, although my colleagues might dispute it a little bit. But the more important thing is the issue you say about the Australians' shortage, and whether or not their disparities or their advantages in practicing there may attract New Zealand workforce over. That's always going to be really, really difficult. It is a matter of international, national and regional planning, and it's very hard to predict. It always has been, and I think it will be, unless one gets in a command economy. In terms of what the government is doing in trying to open up nurse practitioners and nurse prescribing, as I said before, I think it's too slow, but it's vital. And the other part that's really important is we just have to be committed to a collaborative, collegiate model within particularly community medicine these days. That's the reality of it, and there are some wonderful examples around the country.
All right, Kevin and Barbara, I'm going to cut you short. We are actually out of time, but because you are such a energetic and committed audience, and there really are literally tens of questions or questioners who would like to have another go, but sadly can't. I'm going to give one more question, and Joe, it's your turn.
Thank you very much indeed for your involvement today. I'm going to highlight for you an organisation that we've been founding, the Rural Health Alliance Aotearoa New Zealand, bringing together organisations that have an interest in the health and well-being of rural New Zealand. The day before yesterday we had our second annual conference. Federated Farmers, Dairy Women, Rural Women, Local Government New Zealand, a range of PHOs, the other professional organisations, nursing and medicine that are involved in rural health. We have a vision for the health and well-being of for all rural people, and amongst the issues that you've been raising, one of our focuses is on improving the outcomes for Māori health in our rural communities. And one of the issues that we want to highlight as an organisation, as RANZ, is the improving the Māori health workforce. And I'm just wondering if you have any plans or around the Māori health workforce that you can highlight for us this morning.
Kevin, do you want to have first go, since you didn't get a chance last time?
Yeah, well, it's hard to respond beyond saying we totally agree that this is incredibly important. We don't go into that level of detail of specific workforce initiatives in our policy at this point. What I would say is, when I talk about using all of the resources available in rural communities, one of the things that I'm interested in is the established infrastructure that is already provided through marae, through iwi and hapu. In your area, Tūhoi's sort of resurgence. I mean, I know you're not quite Tūhoi, but as a local strength, what is the relationship between health providers and Tūhoi and Te Whanau Apanui? I think that model that I spoke about earlier about the West Coast of actually getting kids interested in the possibility of health careers very early, ensuring they don't turn off maths and science when they're 10, which is typically what we do, and actually building the pathway and enforcing it and resourcing it at every stage is kind of the answer. And that means it's a very long-term project, but one that we have to be fundamentally interested in.
Okay, as far as we're concerned, the concept is very, very positive, but it is difficult to ensure that it actually happens. So, we'd like to see it happen, but how to make it happen is a challenge in itself.
Annette.
You have identified what I think is a real issue, and it's in Māori health. It is not just doctors and nurses. Actually, there is a huge opportunity in community health and in caregiving and so on that is needed within Māori communities. We had scholarships for Māori, and I remember providing some of the graduation certificates, and what interested me was every one of those graduates were going back to their own home area to work, and many of them were in rural New Zealand, and their commitment was to their communities, which is, I have to say, is not the same for other graduates necessarily. So the idea of scholarships and recruitment, and I think that has to be part of your mix, because we talked of incentives today. We need more Māori working in Māori health, but I also think we forget the growing Pacific population in New Zealand, and that there are some real cultural differences in the way we need to provide health, and that has to be not only taught to our graduates or to our trainees and graduates, but we need faces that look like theirs to be providing health. So, I agree that we need ways to encourage other ethnicities into medicine and health, and that I'd be interested to know what the numbers are now. I'm not up with the numbers, whether they've gone up for Māori or not, but I would hope that over time we've seen the value of that.
Paul, as quick as you can, please.
Look, as early as year 9 in counties Manukau, the DHB have organised people to go into schools to encourage science among young Māori and Pacific Islanders, to take them out to the Liggins Institute, to have experience within hospitals, and hopefully to challenge them into going then into a medical career or medical or nursing career. So that has started. It's embryonic. It takes a long time, and then, as you know, there are placements within the medical schools. Obviously, this is something that requires more focus.
All right, I have completely failed to keep us to time, so my apologies. You're starting your conference late, really, before you've begun, but partly you're responsible because the questions were great, and I wish we could have lasted or kept the conversation going a little longer. Can you join me in thanking the 4 guests this morning?
And thank you to Linda for her facilitation of that session. Your enthusiasm has helped us run over time. You've cut yourself short of a little bit of coffee time. Please make your exit through that door to the exhibition, and your next session starts at 11:15. Thank you.